She was 24 years old. Her name? I won't share, but I remember her. She came through my A&E doors screaming. Not crying, screaming. Her boyfriend was trying to hold her up. She couldn't walk properly. She was gripping her lower back, her hips, her knees, all at once, like her whole skeleton was on fire. Her oxygen was dropping. Her heart rate was through the roof. I'd seen this before, many times. This was a vaso-occlusive crisis. And what was happening inside her body at that exact moment was something most people, including many doctors, don't fully understand. Today, we are going inside. If you haven't watched episode 1, here is a 30-second recap. In sickle cell disease, a genetic mutation causes red blood cells to take on a rigid, crescent shape instead of their normal, round, flexible form. These sickle-shaped cells are sticky, stiff, and fragile. They can't move through small blood vessels freely. And under certain conditions, dehydration, cold, infection, stress, low oxygen, they begin to clump together. When that happens, a crisis begins. A vaso-occlusive crisis doesn't happen in an instant. It builds. It has 4 distinct phases. And understanding those phases is the key to understanding why the pain gets so severe, so fast. Phase 1 starts quietly. Sickle cells begin sticking to the walls of the blood vessels. At this point, the patient might feel an ache, a warning. Many patients know this feeling. They call it the prodrome. Something is coming. Then phase 2 hits, and the blockage becomes real. In phase 2, sickle cells, which are sticky on their surface, begin attaching to the vessel wall and to each other. They form a plug. Blood flow slows, then stops. Beyond that blockage, the tissue receives no oxygen. And here is something that most people don't realize. It's not just the red blood cells causing this. White blood cells and platelets join the pileup too. The vessel wall itself becomes inflamed and swollen, narrowing the space even further. What started as a few stuck cells becomes a total blockage, and the pain signal fires. When blood flow stops, the tissue beyond the blockage is starved of oxygen. This is called ischemia. An ischemic tissue does not stay quiet. Within seconds, cells in that tissue begin releasing distress signals, chemical messengers called inflammatory cytokines, that travel to the pain receptors in and around that tissue. Those pain receptors fire, and the signal travels up the nerves to the brain, where it registers as pain. But here's the cruel part. Because multiple vessels in multiple locations can block at the same time, the pain can be everywhere. Back, chest, hips, arms, legs, simultaneously. If the blockage isn't cleared, and in a vaso-occlusive crisis, the body struggles to clear it on its own, phase 3 begins. Tissue cells start to die. This triggers a massive inflammatory response. The body sends immune cells flooding to the area to clean up the dead tissue. But this immune response makes things worse in the short term. It causes more swelling, more pain, more heat in the affected area. The pain in phase 3 is constant, severe, and unrelenting. This is the phase when patients cannot function, cannot sleep, cannot think. Now, I need to tell you about the complication that scares me the most when a patient is in crisis. It's called acute chest syndrome. When sickle cells block the tiny blood vessels inside the lungs, lung tissue begins to die, the same way other tissue does, but the lungs are different. The patient develops chest pain, fever, a cough, and the oxygen levels begin to drop rapidly. Acute chest syndrome can develop during a vaso-occlusive crisis, sometimes triggered by the crisis itself, sometimes by a concurrent infection. It is a medical emergency within an emergency, and it is the leading cause of death in sickle cell disease. The brain is another organ at serious risk during a vaso-occlusive crisis. When cerebral blood vessels become blocked by sickle cells, brain tissue begins to die within minutes, a stroke. During an active crisis, the blood is thicker, the cells are stickier, and the risk is higher. I want you to understand what this means practically. If a patient in sickle cell crisis suddenly develops a severe headache, confusion, weakness on one side of the body, slurred speech, or vision changes, that is not the crisis getting worse. That is a stroke, and every minute matters. Here is what makes a vaso-occlusive crisis so difficult to break. It becomes a self-sustaining cycle. The blockage causes pain, pain causes stress. Stress releases adrenaline, which causes blood vessels to constrict, narrowing them further. The ischemia causes inflammation. Inflammation causes more sickling. More sickling causes more blockage. The body's own response to the crisis makes the crisis worse. This is why, once a severe crisis has started, it often cannot resolve on its own. It needs to be broken from the outside with medical intervention. I want to pause here and speak directly to those of you who have sickle cell disease or who love someone who does. Because the pain of a vaso-occlusive crisis is not like ordinary pain. It has been compared to the pain of a bone fracture or childbirth or a heart attack. In fact, in studies measuring pain intensity, vaso-occlusive crises scores consistently among the highest pain levels a human being can experience. And yet, patients with sickle cell are frequently undertreated for pain. They are sometimes doubted, sometimes told that pain cannot be that bad. I want to be very clear. The pain is real, it is severe, and it deserves to be treated aggressively. Phase 4 is resolution. When the blockage finally begins to clear, either through the body's own fibrinolytic system breaking down the clot, or through medical treatment helping that process along, blood flow is restored. Oxygen reaches the tissue again. The pain, slowly, over hours and sometimes days, begins to lift. But resolution is not the same as recovery. Tissues that were ischemic may take days to fully heal. Some damage may be permanent, and the patient is left exhausted, physically and emotionally depleted by what their body has just been through. Let me take you into my A&E. When a patient arrives in vaso-occlusive crisis, we are working against the clock. The first thing I do, before anything else, is assess the pain. We use a pain score, 0 to 10. If they're scoring 7 or above, we treat immediately. We do not wait for blood results. We do not wait for the full history. Pain relief first. In my department, we reach for IV morphine or pethidine. We give it fast. And we reassess every 15 to 30 minutes. If the pain is not controlled, we give more. Undertreating pain in a sickle cell crisis is not careful medicine. It is harmful. At the same time as pain relief, we start IV fluids. Remember, dehydration is one of the key drivers of sickling. Getting fluid into the bloodstream helps to dilute the sickle cells, reduce viscosity, and start restoring flow. We use normal saline. Carefully, because too much fluid too fast can cause its own problems, particularly if the lungs are already involved. We also check the oxygen saturation. If it is below 95%, we give supplemental oxygen. Oxygen helps reduce further sickling, because sickling is driven by low oxygen levels in the tissues. While we are managing the pain and the fluids, we are also investigating. We take blood, a full blood count to check the hemoglobin level, a reticulocyte count, inflammatory markers, a blood film to look at the cells. We check kidney and liver function. We do a chest x-ray to rule out acute chest syndrome. We check the urine, and we monitor continuously. Pulse, oxygen, blood pressure, respiratory rate, pain score, every 15 minutes until the patient is stable. In sickle cell crisis, things can change quickly. You cannot look away. Most vaso-occlusive crises, with good management, will begin to improve within 24 to 48 hours. But there are red flags I watch for that tell me this patient is in danger. Dropping oxygen saturation, especially below 90%, tells me the lungs may be involved. A fever may signal an infection driving the crisis, and in a patient with no functioning spleen, an infection can be life-threatening. Neurological changes, confusion, weakness, headache. I'm thinking stroke immediately. A hemoglobin that drops acutely means the cells are hemolyzing faster than the body can cope. any of these and we escalate urgently. Before I let you go, I want to speak directly to anyone living with sickle cell disease or caring for someone who is. If you feel the warning signs of a crisis coming, get to the hospital early. Do not wait until the pain is a 10 out of 10. Early treatment means a shorter crisis. Drink water consistently every single day. Know your triggers. Carry your medications. And if a doctor does not take your pain seriously, advocate for yourself. You know your body. The pain is real. You deserve proper care. That is what happened to my patient. She was treated aggressively, monitored carefully, and by the third day, the crisis began to break. She walked out of the wards 4 days later. I will see you in episode 3, where we look at the long-term complications of sickle cell disease, the ones that build silently over years. Subscribe so you don't miss it.